But just know that if you do end up needing insulin or other medications, that's not necessarily a reflection on you, but it's just a reflection on your pancreas that's not doing the best job ever. And you know what? You are more than your pancreas. Hello to all of my beautiful birthing people. You are looking absolutely magnificent today. Today's video is going to be one that is actually pretty highly requested. It's going to be all about gestational diabetes. What is gestational diabetes? Well, gestational diabetes differs from type 1 or type 2 diabetes in the fact that it only occurs during your pregnancy and that it is self-limiting to pregnancy. So when any person is pregnant, their needs for insulin increase because their body becomes more insulin resistant. The fetus and most importantly the placenta are secreting many hormones that cause your body to become insulin resistant. Basically, this is done as a way to make sure that the baby is getting as much sugar and nutrients as it needs from the birthing person's body. Now, most birthing people, their body has the ability, while their cells are becoming more resistant to insulin, to just pick up how much insulin they're making and make more insulin. Their pancreas is able to make more insulin. It's where their pancreatic function is not enough to overcome the insulin resistance, meaning that their cells are not able to get glucose into the cells. The glucose remains in your blood. Your blood glucose levels are then elevated. And that is what we call gestational diabetes. There are about 2 to 10% of birthing people in the United States, and oddly enough, that range can vary from a very, very low percentage, almost 0, to up to 25% in some ethnic groups. So around the world, we're seeing vastly different rates of gestational diabetes. The big takeaway here is that gestational diabetes is not a reflection on you, a reflection on your diet, a reflection on your lifestyle necessarily. It is just a reflection on the fact that your placenta is demanding something that your pancreas is not able to make happen for whatever reason. Even though there are a lot of risk factors that can make this happen, we still have people who have absolutely 0 risk factors who develop gestational diabetes. Some risk factors are, and these are not limited to, and I'm just going to go over them all very quickly, having previous glucose intolerance, having gestational diabetes in a previous pregnancy. If you've had gestational diabetes in a previous pregnancy, your rate of reoccurrence is about 48%, so it is quite high. Being a part of the ethnic groups African American, Hispanic American, American Indian, South and East Asian, and Pacific Islander. Having a pre-pregnancy weight that's greater than 110th percentile of the ideal body weight, or a BMI greater than 30. If you had significant weight gain in your early adolescent years, and also between pregnancies, that can put you at a higher risk of developing gestational diabetes. Being of an older maternal age, and in this case, over the age of 25, which is really not older by any stretch of the imagination. Having glucose in your urine at the very first visit can be a sign that gestational diabetes might be something that will occur. And then also having a baby previously who weighed more than 4,000 grams, or about 8 pounds, 13 ounces. And then having any medical conditions that can be associated with a risk of developing type 2 diabetes. So a metabolic disorder, PCOS, hypertension, current use of steroids, anything like that. Now those were a ton of risk factors, and the thing to keep in mind, about 90% of the pregnant population in the United States has one or more of those risk factors. We still have about 20% of people who have no risk factors develop gestational diabetes. So in the United States, we do universal screening for all birthing people between 24 and 28 weeks gestation. Now, if you have a lot of these risk factors, your OB might want to do a test earlier on in the pregnancy to see if there is gestational diabetes or perhaps overt diabetes that was occurring before the pregnancy started. But this is going to be up to you and your physician to talk about and figure out the plan that is best for you guys. So, testing for diabetes. There are 2 forms of testing that can be done. Typically, what I have seen, what my friends have done in the United States, what all of my patients have done for the most part, is a 2-step testing system. And what this does, the first step is a screening tool, And if you pass that first step, then you don't go on to the second step. If you do not pass that first step, you do go on to the second step. So the first test is a 50-gram glucose drink that you drink, often called glucola. It tastes like flat soda. It often comes in a variety of flavors. It's really hyperosmotic. So for some people, it does cause some nausea and vomiting. Unfortunately, if you throw up, you have to take the whole test over again. You can throw up once you're done with all of your blood sugar screenings at the very end, but if you throw up during the test, it has to be repeated. So for this first test, you drink that 50-gram drink, and you do not have to have fasted beforehand. You can just come in on a regular day. Now, I would recommend making sure that you've had a good balance of proteins and some carbs, like maybe some whole grain toast, and eggs would be a really good thing to have before you come in. That has been recommended to me. And then depending on your testing facility and your lab, anywhere from between 130 to 140, under those numbers is passing. Anywhere over that is you're gonna move on to your 3-hour test. Now the 3-hour test, you do have to come fasted. So this one can be a little bit more tricky because you're having to drink a 100-gram solution, and you get 3 blood sugars at an hour, 2 hours, and 3 hours after drinking that solution. And if you have 2 of those blood sugars greater than the threshold for your lab, then you are diagnosed with gestational diabetes. The other test is just 2-hour test that you drink a 75-gram drink. With this 2-hour test, you are required to fast overnight. And if you have 1 glucose that is above the threshold, then you are diagnosed with gestational diabetes. So because this glucose tolerance drink is very hyperosmotic, like I said, it can cause some gastric irritation, some nausea, and some vomiting. And if you do throw up during the test, you have to repeat the test. So there are a couple options if you're having a really hard time with this test. One of them would be taking an antiemetic drug and coming back and trying again another day. Another one would be just monitoring your blood sugars from 24 to 28 weeks with a fasting one in the morning and then 2 hours after meals as well, and looking at the trends with your doctor. Another option could be candy. I've often heard of jelly beans used, or a predefined meal, or a soda that has a similar grams of sugar as the glucola drink. Unfortunately, those kinds of tests don't have the science to back them up, and they seem to be less sensitive and less likely to be diagnostic of gestational diabetes. So it could be more likely that you do have gestational diabetes and then it slips through the cracks. Why do we care about gestational diabetes? It matters for a lot of reasons, but one of them that I did not realize but found very interesting in my research is that it can put you at a greater risk for preeclampsia and gestational hypertension. It puts you at a greater risk for having too much fluid in your uterus, called polyhydramnios. It also puts you at risk for having a large for gestation baby or a macrosomic baby, so a very large baby. This is really going to be a risk when your blood sugars are not well controlled, and we'll go over in a second what we can do to help well control your blood sugars. Having a baby that is larger, who is large for gestational age, or who is just macrosomic, meaning large, can put the birthing person at risk for trauma with the birth, needing to have an operative delivery, whether that is a cesarean birth, forceps delivery, or a vacuum-assisted delivery. It also puts the infant at a risk for shoulder dystocia, because if we have an infant who is larger, their shoulders are going to be larger and they can get impacted behind the pubic bone, and this can be a medical emergency that can result in oxygen deprivation for the baby. After your baby is delivered, their supply of blood glucose is cut off. The umbilical cord, once it's cut, the baby's in charge of its own blood glucose. But if the birthing person's blood glucoses were high, the baby is used to making tons and tons and tons of insulin. And so the baby is not going to all of a sudden stop making that. It takes a little time for the baby to reel that in. So baby can continue to make lots of insulin and actually have issues with low blood sugar. So after delivery, with gestational diabetes, whether it is well managed or poorly managed, blood glucose monitoring of your infant is going to be recommended by the pediatrician to make sure that baby is able to now kind of regulate its own blood glucose now that it no longer has mom's supply. This often occurs before feedings so that we can make sure that we are catching the very lowest blood glucose that the baby might have for 12 to 24 hours, depending on the hospital policy where you deliver. Other issues that a baby might have if there is poorly controlled blood glucoses of the birthing person is having a high red blood cell count, having low calcium, and then also having a high bilirubin level. can all be issues that arise. And then in incredibly unmanaged and poorly controlled gestational diabetes and diabetes in general, there is a risk of stillbirth, which obviously is going to be one of our most significant risks. It is quite low, and when blood glucoses are well managed, it is virtually non-existent, but it is still a risk that is there. So what are some things that you can do both before pregnancy and then also when you have been diagnosed with gestational diabetes to help keep you and your baby happy and healthy and safe? So before pregnancy, it is recommended that you work on having a healthy diet and exercise. Those are both things that can help reduce your risk of gestational diabetes. And losing just 10 pounds before getting pregnant has been shown to significantly reduce the risk of gestational diabetes. It is also important that if you are a current tobacco user, that you stop smoking, because that is going to do a world of good for your baby during the pregnancy and also can decrease your risk of gestational diabetes and preeclampsia and just a whole host of other issues. Now, in the pregnancy, gestational diabetes is initially attempted to be managed through just a dietary change. And this works for a vast majority of women, but it does not work for everybody. Sometimes dietary changes are not enough and medications are needed, either in the form of insulin or other blood sugar controlling medications. Sometimes metformin might also be used. When you're looking at eating for gestational diabetes, you can get lost in the mindset of like, carbs are bad, I shouldn't eat carbs. It's really not about that. First of all, it is unique to every individual and every living person how their body is going to react, how their blood sugar is going to react to what they eat. So first and foremost, might I recommend, if one has not been offered to you, to ask for a referral to a registered dietitian. And if one has been offered to you, please take it. The registered dietitian that works with gestational diabetic patients at my hospital says most people don't make or keep their appointments. And I think that that is just a travesty, because it is such an amazing resource to have for you to figure out what things you can eat, because it's not always intuitive to make sure that your blood sugar maintains well controlled. So in general, it's recommended that you eat 3 meals and 4 snacks throughout the day to kind of keep your blood sugar quite stable. This helps making sure that it doesn't have rapid peaks and falls. Eating every 2 to 3 hours, again with those snacks and meals, is going to help keep things stable. And this is crucial and seems kind of silly. That bedtime snack, super important for keeping your fasting blood sugar good throughout the night for when you check it in the morning. So figuring out the perfect bedtime snack for you and making sure that you eat it is great. And what we're looking at is a really good combination of carbs and protein together that can work together to, 1, give you energy, and 2, keep your blood sugar down. Obviously, we're going to be avoiding a lot of sugary sweets, a lot of pre-sugared drinks such as Coca-Cola or sweet tea, while also making sure that we are, when we're looking at carbohydrates, choosing healthy whole grain carbohydrates over refined grains when possible. Depending on how reactionary your blood sugar is, you might have to play around figuring out how much fruit and what fruits go best with you. And many dietitians actually recommend not having fruit with breakfast just because it can spike your blood sugar really early in the morning. And many vegetables, including leafy greens and salads, are going to be great low carb options for you. You can dress them up with some really good like nuts and healthy fats. What we're going to be looking at for healthy fats are like avocado oil, olive oil are all great options. Maybe putting some chicken on it. That is going to be a really good meal that's going to keep you full and satiated, but also not spike your blood sugar. And that's really our goal, is making sure that our blood sugar stays quite nice and contained throughout the day. Checking your blood sugar, obviously refer back to what your physician is recommending for you, but in general we see patients checking a fasting blood sugar in the morning and then a blood sugar 1 to 2 hours postprandial, which just means after meals, so after breakfast, lunch, and dinner. Exercise during pregnancy, and this can be as simple as getting out and going for a walk, can be really beneficial in helping keeping those blood sugar levels at a steady level. If you are adding new exercise, make sure that you check with your doctor beforehand to make sure that what you're doing is safe and healthy for your specific case. Now, even if you're doing your diet perfect and you are really listening to your registered dietitian and your OB and your body, and you are doing the very best that you can, even with all of that, still about 15% of women need insulin. and that is okay. That is not your fault. Your insulin requirements are going to be different based on each individual person. So I'm not going to sit here and go over all of the different insulin requirements. I think that's a really important conversation to have with your OB, and they'll probably send you to a diabetes educator to make sure that you know how to properly give yourself insulin and to monitor your blood sugars and all of those good things. But just know that if you do end up needing insulin or other medications, that's not necessarily a reflection on you, but it's just a reflection on your pancreas that's not doing the best job ever. And you know what? You are more than your pancreas. Now, towards the end of pregnancy and once you have gestational diabetes diagnosed, depending on how well it's controlled and whether or not you're using insulin will depend on how frequently and how different your monitoring looks to a pregnancy without gestational diabetes. There might be a recommendation for induction, just depending on your specific medical history and how your pregnancy is going, how your blood sugars are contained. At about 36 to 39 weeks, they probably will do a growth scan to see how large your baby is. It's tricky because these growth scans are not super accurate, and we know that, but they are the most accurate thing that we have at this exact time to look at the size of the baby. If your baby is measuring greater than 9 pounds, 14 ounces, a cesarean birth is something that might be offered. It's not something that you have to do, and it's something that you want to talk with your doctor about and figure out the best plan for you. Towards the end of your pregnancy, you might also be coming in more frequently for having non-stress tests. I have a video all about non-stress tests. I will leave it up in the iCard. Basically just monitoring baby, making sure that baby is happy and healthy and safe in your uterus. When you go into labor, your nurse will be monitoring your blood sugars more frequently because often because of the needs of your body and the energy that you're using during labor, the lack of eating typically that happens during labor just because there is some nausea associated with labor, you're not eating big meals. If you're on insulin, you probably won't need it or won't need as much. So we will be closely monitoring your blood sugars during labor. And then once labor is done, we might do 1 or 2 more blood sugars, but then it might just be done. Because once we get that placenta out and your insulin resistance goes down, your body starts being able to handle it much better. Between 4 and 12 weeks after your delivery, you will go back more than likely and be prescribed another glucose tolerance test to test and make sure that your blood sugars have gone back to normal and that we weren't dealing with type 2 diabetes that we thought was gestational diabetes. So what can you do after delivery to decrease your risk of developing type 2 diabetes, to decrease your risk of developing gestational diabetes again? First and foremost, breastfeeding is going to be something that is going to be really, really beneficial. It helps with insulin resistance, and it's going to be really beneficial for you and for your baby. So if you choose to breastfeed, just know that it is a great choice for blood sugar management. Like I said before, about 48% of women will get gestational diabetes in the next pregnancy. So what you can do in between, keep up your healthy eating plans, keep up your exercise. Those are both things that can be beneficial. Okay guys, so I hope that this video has been helpful for you. I know that it's a long one, it's a lot of information, but it's really important, and I think that it's something that doesn't get talked about as much as it needs to, because there is no shame about having gestational diabetes. There is no shame about needing to take insulin. Doing what is healthy and safe for you and your baby to make sure that you have a healthy and safe delivery is going to be so important. And I am so proud of you for doing those steps and taking those steps for your baby and for yourself. Thanks so much for watching. Bye guys.